our communities to vaccinate people at home, we realize that this is a real logistical challenge for everyone. And we want to be able to get patients vaccines as soon as possible. So we're really fortunate that we have one agency, Central New Hampshire VNA, that actually did a pilot program in the last month, working with its regional public health partners to vaccinate patients. And that team has really learned a lot about how we can make this successful. And so I'm excited that Lori Nash and Schelley Rondeau from Central New Hampshire VNA have agreed to share their insights with all of us. So with that, I'm going to turn it over to Lori and Schelley, and they're going to walk through a PowerPoint presentation, and then we'll have time for questions.
Great. Well, good morning, and thank you for having us. I'm Lori Nash, Director of Operations and the Emergency Manager at Central New Hampshire. And with me is Schelley Rondeau, our pediatric RN, but she is also our vaccinating RN and has been instrumental in making this happen. Nobody wants me to be poking arms. So I get to do what I do best, and she does what she does best. So hopefully between the two of us, we'll be able to answer most of your questions. I'm going to start by sharing my screen. Okay. I don't seem to have access to share yet. Yeah.
Leslie, you're taking care of that, giving her access?
She did.
Great.
All right. Can everyone see that?
And I would just ask for everybody else who's on the call if you could mute your lines, except for Lori and Schelley as we go through this, and then we'll open it up. And so some folks have asked, will the slide deck be made available? And yes, we will send a PDF of the slide deck to all the participants after the call.
Great. So everyone should be seeing our first slide, Vaccinating Homebound Patients Lessons Learned. Okay.
It's up there, Lori.
Okay, great. Thanks. For those who haven't heard about our process and how we got started with this, we were working with our public health networks back in January, beginning in December, but back in January mostly, to acquire vaccine as a closed pod for our staff and our volunteers, as we were trying to vaccinate those that were in phase 1A, 1B. A lot of the lessons learned were from those closed pods that we did here in the office, where people came to us. And then near the end of our vaccination cycle with our first round of our staff and volunteers, we were asked to utilize some vaccine that was going to expire in the public health region in Carroll County. So we took the opportunity to utilize that vaccine and reach out to some of our patients who had contacted us and asked us for help because they were unable to get to a fixed site and they weren't sure what they were going to do. So they were hoping that as our home care and hospice patients, that we could meet that need for them. So we took the opportunity to reach out to some of those in the Wolfboro area, trying to stay within the town because we were concerned about the vaccine transport and making sure that we were able to keep it at temperature. And that's how we began testing and piloting the program for our patients. We were able to vaccinate 12 of those homebound patients during that pilot process. And we learned some things, and we were very pleased that we started with a soft opening. But we couldn't have done it without a public health network. So I thank them very much. And it's important to mention that as we all walk through this process together, that our partners are going to be necessary for us to rely on. Some logistics that we had to start with is we had to know what our capability was. We started out thinking that we were going to have 4 vaccinating nurses by the time we got to the point where we were going to be able to vaccinate our patients. That turned out to be 1, which is Schelley. And then we were able to acquire another volunteer vaccinating nurse that we have on staff. She stepped up and agreed to vaccinate our homebound patients as well. So we are up to 2 nurses to help move forward to get our homebound patients' needs met. You'll need to contact your public health network. There's a couple of roles that they will play. You'll need to work with their emergency manager. They are responsible for emergency support function 8 in the state of New Hampshire, which is the public health. And we've been part of those public health networks for quite some time, practicing and doing drills regarding mass vaccines. I have to say this looks a little different than what our drills were like, but it wasn't a far stretch. With flexibility and creativity, we're able to get it done. We had to, when we transitioned from a closed pod with our staff and our volunteers prior to us being able to move forward with our patients, we had to complete a provider agreement with New Hampshire DHHS. And there are links throughout the slides and in the resource section on how to locate some of these documents that I mentioned. Hopefully that will help you in getting started. There's also an opportunity to establish a contract with DHHS if you're going to be providing the vaccine nurses yourself and going out to doing your own vaccine to help with some of that financial assistance. You'll need to obtain a standing order to vaccinate your patients. The state will not provide that standing order for you, mostly because of my understanding is the transport need or requirement in the situation. So your medical director will have to give you that standing order. And there's some VAMS training. VAMS is a state portal. It's an electronic web-based portal. It stands for Vaccine Administration Management System. There's some training that you'll need and some setup that you'll have to do or have done for you in VAMS and that's where you're going to log your recipients and assign your recipients a dose of vaccine. The standing orders for your vaccine there's one for each vaccine. So Pfizer, Moderna, and Janssen all have their own standing order. Janssen's J&J standing order was released sometime over the weekend. I was able to find it on Sunday, so I've added it here as well. So these links will take you to the standing order. The standing order signature line has patients only in the bottom of what your medical director will be attesting to. You can use an Adobe Pro or Adobe Writer application to modify that if you need be, to add patient, caregiver, or other community members, whatever your agency is going to be willing to or able to do and your medical director is willing to sign off on. The VAMS portal, we needed to connect with our public health network partners for setup and the training resources. So there was a brief webinar that we had to view, and that walked us through how do you set up users in your system, what roles to assign those users. So think about who in your agency may be monitoring or adding the inventory. Who is going to stage your patients or the recipients of the vaccine into the VAMP system. So you'll be entering their name, date of birth, address, and then who's going to be assigning that one of those doses from your inventory that you entered to that recipient once the clinic is underway or once that patient has been vaccinated. You can set those people up. We have two portals in our VAMS. So I log into VAMS on a dashboard. I have an option for a Carroll County and Central portal, and one for Winnipesaukee Public Health and Central portal. You have options of setting up as a mobile clinic or as a third party. We were set up as a third party. I mention that because that might be part of our success, is how we were set up. We didn't need to put in emails. Nothing went out to the patient to schedule. When we started this, we were really looking to give our staff not give them the opportunity of picking a date. We wanted to make sure that we were choosing dates for them and we vaccinated them on a Friday, making sure that they weren't going to be working the weekend. So we kind of told them when to come in. So in order for us to be able to make that work, we had to be a third party so we could control the distribution. We decided to keep that model if at all possible. I'm not sure if it'll change moving forward, but currently that is how we have it set up. Then we had to identify our patients. We realized that many of our patients, and the way the vaccine was rolled out in the state, were going to be able to have somebody help them get to a fixed site. And with the phone calls that we were receiving asking for assistance from patients, those patients were patients who identified themselves as profoundly homebound, where they were not going to be able to get to a fixed site. So we started focusing on this list, and we started making phone calls to our patients to start identifying them. And we found that this was a laborsome task. So then we took to our case managers, and we asked our case managers to look at their list of patients and to provide us with those patients that they felt were profoundly homebound, and asked some questions of those patients during their next visit. So what we needed to know was, have they already been vaccinated? Did they have an appointment to receive vaccine? If they had an appointment already, did they realistically had the ability to get there? And if they answered no to all three of those, and then we asked them if they were interested in the vaccine. As we went through the process, we learned that we also had to ask if they had gotten sick in the past 30 days, or if they became ill with COVID-19 or were exposed and were currently waiting test results. It was discovered throughout the process that if you vaccinate too soon after an actual infection, then it caused complications for the recipient, and we did not want to do that to them. So we had to add that question to our screening. And this I'll stress often throughout the presentation, is our standby list. Your standby list is going to be driven by your standing order. What does your standing order allow you to do, and who does it allow you to vaccinate? Your standby list should be, is there a question?
No.
Okay. Your standby list should be tied closely to the phases that the state is putting out in the guidance for who can be vaccinated. I would encourage you to keep a standby list of anyone who has contacted you to say, we need your help and we would like to be vaccinated. For us, it started out with staff and volunteers. And then as a closed pod, traditionally, you would be able to reach out to family members. So we made an ask of family members of our staff and volunteers who were 65 and older, and we put them on a standby list. And then when we ran out, we had to reach out to some community members as well who fit into the phase 1A, phase 1B category. So we separated our standby list with those that were homebound and those that can get to a fixed location. And I'll talk a little bit more when we talk about what happened in practice on why we had to separate those two populations. The standby list has helped us make sure that we have not wasted any vaccine, which we are, after 190 shots that we've given so far, we have not wasted any, which we're pretty proud of. And through our lessons learned, this has become critical for us and for our local public health network. we've utilized each other's standby list when we find ourselves with extra doses, then we need an arm to put them in. Then you have to know your vaccine. Up until, well, so far, we've only been vaccinating with Moderna. So a lot of the data that I talk about and a lot of the experiences I talk about is with the Moderna vaccine, being given a 10-dose vial, consistently drawing 11 doses, and then running into situations where we suddenly had 12 doses out of our vial. And I'll talk a little bit more about what we discovered and how we were able to do that. But there's lots of similarities for storing and transporting these vaccines, but there are some subtle differences that are important to note. I put this information on this one slide because none of this information is in one place. So the information was gathered mostly from the documents that you see in the hyperlink, but a combination of the CDC website and the New Hampshire DHHS website and across several documents. So I tried to make it as friendly as possible for you. Pfizer and Moderna, it's important to note that you will be visiting those patients twice, once for their first dose and then once for their second dose. Pfizer is 3 weeks past the first dose, 21 days, and Moderna is 4 weeks between doses, or 28 days. The vaccine needs to be stored for both of those from between 2 and 8 degrees Celsius. The unpunctured vials shelf life for Pfizer is 5 days. That is not 5 days from the date that you get it in your possession. It is 5 days from the time the state thaws that vaccine and prepares it and then ships it to the public health network to get it to you. Moderna has a more user-friendly shelf life, and it's 30 days that you have to use that vaccine. Either way, once the seal is broken, you only have 6 hours to get that vaccine in arms. The 6 hours are going to be easy to obtain with a Pfizer vaccine. You get 5 to 6 doses. It is worth noting that each dose is 0.3 milliliters, which is not the same as the Moderna and the Janssen vaccine. Those are drawn at 0.5. The Moderna vaccine is 10 doses per vial. We were consistently drawing 11. And if we used a certain syringe, then we were able to get 12. And the first time we received those syringes and we did that and got 12, we were a little stumped, and we had to find an extra arm because our standby list, it was early on and we were planning on that one standby. We had to come up with a second arm in a hurry. And the Janssen vaccine is 5 doses. And so we have not used Pfizer and Janssen yet, so I can't tell you what the actual is. But we can go by what they're telling us is in the vial. In order to transport our vaccine, we had to test our equipment. It is advised that you use a soft-sided vaccine cooler. There is a training that Schelley and I both took, and we've asked our second vaccinating nurse to also review that training. It talks a lot about the integrity of the vaccine and the ability to transport and the importance of the temperature monitoring. So we will have a temperature sheet with our nurses throughout the day, and anytime that they open and close that cooler, they will be taking the temperature from a data logger, which is important to note that it has to be a data logger for refrigerator temperatures. They do make them for freezers as well, and you have to ensure that it's a refrigerator thermometer or data logger. Schelley was able to use solid ice packs in our vaccine coolers, in which case she found that she needed to prep the cooler an hour in advance so that it wasn't too cold and that she could get the temperature at the right place. There's also a frozen water water bottle method that can be found in the link under resources for vaccine storage and handling that offered some better consistency with temperatures. But this is something that you should test with your coolers. Each cooler being a different size may have different, you may have a different experience. She found that she needed to get the cooler temp within that range. It took about an hour to do so. She was able to test with her water bottles or her ice packs, how long would that cooler keep at that temperature before dropping too low. And she found that it took about 3.5 hours before she needed to adjust her cooler with additional ice packs to keep it within range. And then because the vials are small and they're made of glass, she wrapped those vials in chucks to provide cushion and protection for that vaccine. Detailed questions about this process, I will defer to Schelley. Then Schelley realized that when she first went out to the home, she was bringing her tote with her that she would use for her vaccine clinics here in the building, and realized it was rather large and decided to downsize. And she was able to put what she needed for the clinic, the vaccination process in each home in a small shoebox size clear container with a lid. And these are the items that she put in that container to make sure that she had what she needed. It's important to note that the recommendations for epi is that you have 3 doses available to you in your kit that you're bringing into the home, as well as Benadryl. Other items here, if you're familiar with flu vaccinations, are pretty standard and pretty normal: alcohol wipes, gloves, chucks to protect your surface. When it comes to the syringes, we were using 1 cc syringes. The tuberculin syringes were slightly smaller, and those are the ones that, when used, gave us the 12 doses of Moderna. There is paperwork that you will need to provide to your patients, and there are vaccine cards that will need to be completed and provided to your patients as well. The handouts that are required to give to your patients, there's going to be a pre-screening questionnaire that you must complete for each recipient of the vaccine. This is a questionnaire that's going to ask things like, have you had any history of anaphylaxis? Do you carry an EpiPen for any allergies or any reason? Do you have allergies? What are they to? Are you immune compromised? Those clinical questions that need to be reviewed with the patient, between the patient and the nurse. There's a fact sheet for each vaccine that gives the patient the information about each vaccine and what the routine side effects are or have been, as well as the ingredients that are in the vaccine in case they have any allergies to any of the ingredients. That's something that should be reviewed with the patient. The clinician Schelley became very familiar with that fact sheet so she could answer questions as needed that came up during her vaccination process. Because we're entering the information into a state electronic portal, there's the New Hampshire DHHS privacy practice notice that should be issued to your recipients, because their information, their name, address, date of birth, which is all considered PHI, is entered into an electronic portal. And then there's an after visit summary and recommendations for vaccine recipients that was on the DHHS website that we were asked to provide as well, and a VSafe brochure. So VSafe is a portal that it is encouraged for recipients to register themselves with VSafe in order to document or record any side effects or reactions that they may be experiencing from the vaccine, and it allows somebody at the state to monitor them and ask them questions, and they'll get emails or notifications asking for an update on how they're doing, how they're feeling, if they had any reactions. I'll talk a little bit about what happens if there's a severe reaction and how that gets reported in a little bit. Central also included a consent form. We revised our flu vaccine consent form. We modified it to answer some of the questions that are in the VAMS system. We decided as an agency that we didn't need an RN to do the data entry into VAMS, but I did need an RN to answer some of the questions that were asked in VAMS. So initially, anybody who can data enter, put in the name, the address, the date of birth, the sex, and male or female, and whether or not the pre-screening checklist was completed. And if you're doing it in the building and people are coming to you, it's pretty easy to fill that out and register them that day. But when you're in the home, you need that consent form and the signed checklist from the clinician, from the RN, to say, yes, this was done. And then when you assign a dose of vaccine to the recipient from your inventory, there are questions that ask you, was the vaccine successful and was there any waste? So we added a spot on our consent form that just said, check here if there was any waste during this vaccine. And Schelley's signature at the bottom of the consent form told me that this vaccine was successful. So I was able to answer those questions in advance. So Schelley was able to bring these consent forms back to the office so that I could enter the information. It's recommended for ease of use with the system that you document this information same day. It's date driven and the dates default to today's date. It's not critical because you can change the date and backdate it to yesterday, but it makes your life a whole lot easier if you do it same day. This is going to be the hardest. Well, this has been and continues to be the hardest part, is preparing that recipient list. We are able to keep a list of our patients who have made an ask, or the patients who our clinicians have sent us names of that have asked them to be added to our list. What we're finding is that some of these recipients have probably put out an ask at several different places. So when we go to make phone calls, last week prior to doing clinics or going out to the patients' homes this week, many of them have already received their vaccine. So you're going, or many of them don't answer their phone. So you're going through your list and you're trying to pull 12 recipients or 9 homes with a couple of caregivers to go do a day of vaccinating. And it's if you're a nurse, as you know, it's not a home care nurse, it's not always easy to get them on the phone and to get them to answer it. But it's harder to make sure that you're capturing 12 people who are still in the same boat, who haven't been able to get their vaccination. So the keeping of the list has been probably the most cumbersome portion. Once you've identified your people, think about your towns and your travel between your patients and the vaccine that you're going to be using. So for us, it was Moderna. We had 11 doses to administer in 6 hours. Schelley discovered it took roughly 45 minutes in the home of the patient for each patient to complete the paperwork, to review the vaccine with the patient, to provide the vaccine, and to monitor that patient for the approximate time frame of 15 or 30 minutes based on the answers for their pre-vaccine checklist response. Once you get your vaccine list together and you know how many people you're going to be able to vaccinate, you'll be able to know what vaccine you're getting. You'll need to order your vaccine currently through the public health network. Currently, we are not ordering it ourselves and having it delivered direct. We are working still with our public health network to obtain the vaccine. We were calling up our emergency managers and saying, okay, I'd like 1 vial of Moderna, right? Because that's what they were getting. So yesterday we were having a conversation that we're going to have to change our verbiage because we don't know whether we're going to continue to get Moderna or they're going to switch us to Pfizer or maybe Janssen. So we will now have to change our verbiage and tell them how many people we plan on vaccinating during our clinic date. So for example, we're going to be vaccinating 12 people on Wednesday. So we need enough vaccine to vaccinate those 12 people. And then based on whichever vaccine is provided to the public health network, we'll ensure that we have enough for the 12 people that we vaccinated in lieu of asking for 1 vial, not knowing what vaccine we have. We could potentially run short if they give us Pfizer and we're expecting Moderna. Some logistics that you'll have to work out with your public health network is, will they deliver the vaccine to you? If they do, is it going to be the morning of, or is it going to be the day before? Do you have refrigeration to store your vaccine in a vaccine fridge that is data logged for temperature? How often are you checking that temperature to make sure that the vaccine stays between 2 and 8 degrees Celsius? Or will you be going to a location that your public health sends you to pick up your vaccine? This was this next slide talks about an approach we took that you vaccinate them, you own them. We chose this approach because we started asking ourselves very quickly, what happens when the patient gets discharged? What happens if they're on service when you start, but in 28 days, they're no longer your patient? And we decided a couple of things. We decided that for ease and for the patient, for the recipient, and for other vaccinators in the state, so the fixed sites and the public health networks, that if we gave them their first dose, we own them and we're going to give them their second dose. It helps in ensuring that when you order your vaccine, that if you had 11 doses on February 5th, that when you distribute your second doses on March 5th, that you're going to be distributing those 11 doses in the same 11 arms. We also took the approach that if someone had called us and asked us for help while they were on service, and they had been discharged shortly after, that we did not take them off our list. These people were calling us to ask us for assistance because they needed assistance and they couldn't get to a fixed site. So whether or not they were discharged didn't cause us to remove them from our list. They stayed on our list, and everybody was told that we are trying to acquire vaccine and we will let you know as soon as we have some, and we will schedule a time with you. And the response was absolutely amazing. And people are very grateful when you can help them in these situations. On that vaccine card that you give out to your patients on their first dose, there's a spot on the back that allows you to put in their date that they will be receiving their second dose. I encourage you to book that date in advance on your calendars so you're not double booking a clinician with first vaccines and second vaccine doses on the same day. It can be the day after day 21 or 28, but it can't be before. So if you think about your patients, we wanted to make sure that we were vaccinating Monday through Thursday. And I'll talk about what we did and why we didn't want to do that on a Friday. And maybe their second doses were Tuesdays and Thursdays. So your vaccinating nurse may be out Monday through Thursday, or just 2 days a week, but that way you're able to get through first doses and second doses without double booking anybody. On the day of the clinic, we provided a spreadsheet with all of the names, addresses, and information, phone numbers, information needed for our vaccinators. All of the paperwork that they were going to need to provide to the patient was given to the RN. Schelley found that it would be very helpful if we pre-filled the demographics portion of the consent form ahead of time prior to going into the home, because she felt that the paperwork took an extra 10 minutes that added up throughout the course of her day, that was unnecessary, having the patient fill that out while you were there waiting. So we took to filling that out ahead of time based on the information that we had in the medical record for the patient. If we were doing a caregiver, the caregiver was able to fill that out while discussions were occurring or during the wait time. Vaccinators will have to have a standby list. So Schelley went to do a clinic yesterday for homebound patients in Wolfboro. And this was her first day at trying to vaccinate all 11 individuals in the same day with Moderna vaccine, and discovered that one of our patients had ended up in the hospital, right? We are home care, it happens. And that patient wasn't going to be available for us to give vaccine to. And another patient was not home, not found. And she needed 2 additional arms to put that vaccine in. And of course, it wasn't at the beginning of the day that she learned this. It was near the middle of the end of the day. Schelley had with her a standby list. I also had a standby list here at the back office. So had her list run dry and she wasn't able to reach anyone, she could have reached out and I would have helped to try to find some arms. This is the importance of having your standby lists separated in homebound and not homebound. So because it was near the end of her clinic, she reached out to a couple of people that she knew could meet her, and she asked them to meet her back at the agency's office in Wolfboro. And they came in and she vaccinated them as if it was one of our closed pods for our staff. So they were able to meet her there and she was able to get those extra 2 doses in arms. It's okay to have a healthy standby list. Your communication with those individuals will be that they are on a standby list if you have extra doses, and they'll have to be available on short notice when you contact them. And then Schelley brings me back the forms and I fill out the VAMs. For follow-up, we felt it was important because these people are in their homes that we should call them the next day to check on them and see how they were feeling as we started learning and experiencing ourselves about some of the responses that people were having to the vaccine. She wanted to make sure that the patients were feeling okay and that what they were experiencing was not a severe reaction that needed to get reported. During that phone call, she encouraged them to register with vSafe so that their individual experience could be reported and recorded with the state. There is a system on our next slide that I'll talk about of how, as the nurse, what the expectation is for reporting a severe reaction. We had reached out to our physician practices and prior to our first run through, trying to figure out what kind of documentation we needed to put in our electronic medical record that we had vaccinated these patients and what the PCP was going to request. And we were hoping it wasn't going to be an order that needed to be sent out with that medication on it for the physician to sign and make everybody's life more complicated with paperwork. But all they really wanted was just a faxed copy of the consent form. And that was all they needed to put in their patient's chart to say that this patient had received their vaccine from us. We did put something in our medical record stating that we had provided the vaccine, much like we do when we provide the flu vaccine for our patients. And Schelley puts a note in the medical record during the follow-up to say that she had called and that whether or not the patient was feeling well or they had experienced any reaction. And then if we need to send out a nurse, we can send out someone to follow up with them, which is why we chose not to vaccinate patients on Friday, because our weekend nursing staff is limited. This is taken directly from the VAERS website. VAERS stands for, let's see, Vaccine Administration Event Reporting System, something like that. And I like acronyms. Don't always know what they mean, but I do like acronyms. So this is taken directly from their website about what is expected of us as healthcare providers and what is reportable. The VAERS table for reportable events following vaccine is helpful for guidance on what types of events to report. This was brought up in one of the DHHS calls, the Thursday calls with the home care agencies. There is nothing specific for the COVID vaccines. It talks a lot about the flu vaccines and different, Hep A and other vaccines, but it gives you a really good idea. And if you have any questions, reach out to your medical director or your public health network emergency managers. They've all had experience thus far on what is reportable and what can be just simply entered by the patients into vSafe. When it comes time to do your second dose, I was under the impression that, phew, the hard part is behind us. And getting people who want vaccines scheduled and their appointments made and getting the clinician getting the nurse to get them vaccinated, and come round to, all I had to do is reach out and tell them when to show up, right? Someone's not going to show up for their second dose, or someone's not going to be available. So we found this both in our closed pod for staff and volunteers. We also found this with our patients that we did a trial with. Someone ended up in the hospital. Schelley was able to reach out to Huggins and say, hey, I know this patient is there with you and he's scheduled for a second dose of vaccine today. Sounds like he's going to be discharged today, so he's in good shape. Can I come give him his vaccine? And they're like, no, you can't come in. We'll give him his second dose, and thank you for notifying us. That's great. The patient got what they needed. We had an extra dose in our hand. So now we had to figure out, well, what do you do with a second dose? Now, the vaccine itself is the same. Nothing changes. It's the same vaccine that you have for your first dose. The caveat is you don't have another dose of vaccine coming 28 days later to cover that if you were to give it as a first dose. So we tried really, really hard to find someone who needed a second dose. What we learned was in phase 1A, 1B, there were healthcare workers that had received their first dose at a clinic in Tamworth that was shut down by the state, and those vaccinators were moved down south to help with some of the congestion and the backlog that was happening down there. But those folks weren't able to get re-registered for their second dose. So when we reached out to our other home care and hospice agencies, we found a couple of clinicians that this had happened to, and they were able to come over to get their second dose because, coincidentally enough, they were due, and we were able to get them. The next time it happened, we had to reach out to our public health network and say, hey, do you have anybody on a list who's waiting for a second dose? And they said, oh yes, we have this agency who have a couple of staff who weren't able to get their second dose, and they were able to send them over. As a last resort, we became a little more desperate, and we had to seek people out who needed their first doses. We found individuals that had already registered with the state for a fixed site, but their registrations were booked out until April and May. And this was pre-racetrack vaccine, so the light wasn't at the end of the tunnel for them at the time. We asked them to keep that clinic date, but we would provide them their first dose because they had an option to choose Moderna or Pfizer. We asked them to make sure they chose Moderna for their clinic dose. And then their second dose would be that dose they received at the stand-up site. Not ideal, but that did happen. If we were doing a larger clinic and we weren't vaccinating people in 12s, the public health network that I spoke to had reported that they ended up was able to do a separate clinic just for all the people who they had given first doses to during a second dose clinic so that they could follow up with them and make sure that they received their vaccine. So that's an option too. It just depends on what your volume looks like and what your capabilities are. And then we're at the resource slides. And I guess at this point, we can take questions that you might have. Happy to answer them. And I can stop sharing my screen.
So Lori.
Thank you so much, Lori. That was great. We do have some questions in the chat, but before we take those, I'm going to open up to Schelley just to see if there's anything that you want to add or comment on about what Lori just shared.
So Lori did an awesome job. It's basically everything she said is correct. One of the questions was a soft cooler. It is a soft cooler, but it has the hard inside. So, and I am using little small water bottles and then a small ice pack in between. So that works for our cooler. So the data logger, I check I found taking pictures of it works for me better. So when I open it, I take a picture. When I close it, I take a picture. And at the end of the day, I print those pictures off. So that just works better for me time-wise. So you're going to find what works for you out in the field. In communication, everybody's got to, I don't know how many times a day Lori and I talk when I'm out in the field, at least 1 million. So
Schelley, do you find that it's really helpful to have, you say you talk to Lori a lot, to have somebody at the office who's there to support you and help with scheduling and answering questions and that sort of thing?
Yes, when we first started talking about this, I thought, oh, I can do this. I can do this all by myself, and there's no way. It takes 2 or 3 people, because the office gets a phone call. Like yesterday on our client that was in the hospital, I've been trying to call him. I left messages. Hospice got the phone call. Lori, they finally got a hold of me, and we were able to figure it out. You just have to go. You have to have that backup list. If I didn't have that backup list, I would have wasted some doses, and I'm not wasting doses. My name is not going on that list at the state as a wasted dose.
So one of the things we did have to, Schelley says it takes 2 or 3 people. We had to make sure we looped in our operators. Initially, when we were playing or piloting, and we were like, okay, let's go do these patients. We hadn't told our phone operators what we were doing, and they started getting phone calls, and we're like, oh yeah, you guys probably need to know this, right? And then yesterday, when Schelley got the late notice that a patient had gone into the hospital, we're like, oh yeah, we should probably publish the list to our managers and case managers so that they know that their patients are getting vaccinated. And should someone end up in a hospital, then they can tell us as soon as they know. So yes, it takes the agency really. But we needed to not hold the information as tight as we've been holding it, and we needed to get it out there to a few more people than we had been.
That's great advice. Great advice.
The other thing is,
go
the other
ahead,
thing
Schelley.
is to map out your plan. For us, it's a big region, so and that's why we're doing it town by town, so that I can stay within that town. A couple towns can be combined, but for us, it's a big region. So make sure you map it out, because you don't want to go from from Guilford to Belmont for me would be another 15 minutes, you know, so because that 6 hours goes pretty fast. You don't realize it. And then if you got traffic or you hit construction or you get behind a truck that goes 2 miles an hour.
Schelley, I see a question in the chat about drawing up your vaccine ahead of time. You found a way to make this safe so that you aren't risking contamination or leakage. Could you speak to what you did?
Yeah, so what I did was I drew them up and I put them each, obviously I wrapped, I kept the needle in the packaging and put the needle onto the syringe really tight. And then I wrapped each syringe in a plastic bag separately. So you have 10 to 12 bags, and then wrap those lightly in the chucks or the bubble wrap. And I haven't had any leakage or any problems, so.
So Schelley, so one of the questions then, just to elaborate on that. So you basically drew up all your vaccines at the agency before you went out on the road versus opening the vial and at the first visit. Yes,
I've done both.
Okay. And which do you think works best?
It depends on if you're conquering, if you got 2 nurses out there, you're going to have to open up that vial and split it up. If you are doing it all by yourself, then you can do it, you know, draw it up at each home. I don't think it added, it didn't seem to take away the time. The paperwork is a time consumer, especially if you get a person that doesn't have a caregiver, can't find the Medicare number, you know, that takes a lot of time. So having the paperwork done ahead of time, it does help. So.
So another one of the questions was about VAMs. So June from Cornerstone said that she completed the VAMs training yesterday, and they stated that point of care VAMs documentation was the best practice. But the system that you've described does not have the clinician entering VAMs. So Lori, you're the VAMs point person. Can you just elaborate a little bit more on that process that you described?
So we were told that point of care VAMs entry is ideal. I hate to publicly say that I disagree. It would be complicated. We didn't have the tools to send Schelley out into the home with a device that she could access the internet on in the homes, especially in some of the towns that we were going to be in, didn't have great cellular coverage. So we were trying to make sure that she was successful and wasn't adding the complications of technology to that piece as well in the home. When we were here in the office and we were doing our staff and our volunteers, yes, absolutely. Schelley and I sat near each other and we were doing the registration and the VAMs data entry at the time, right? Because that's what works really well. But when you're getting into the homes and you're at the mercy of technology and cellular capabilities, we weren't sure it was going to be successful, which is why we mirrored our consent form to the VAMs questions so that Schelley's signature and how she answers that consent form or what she checks off in that consent form gives me everything I need to know to data enter it into the system after the fact.
There is no way that we could do that data entry in the homes. The broadband is horrible up here. There's just no way.
So Schelley, let's assume that you had good internet access. Would it just take too much time though in the home for you to do the VAMs?
It would add extra time, yeah. I mean, okay. You're probably looking at an hour and 15 minutes per patient. That would certainly cut down on the amount of patients you can do.
Okay. So another question that came in was that last week with the commissioner, we were told not to pre-fill syringes and also to use the hard cooler and not ice packs, and asked if I could get clarification on that. So I don't recall them saying we shouldn't pre-fill syringes. I think it was you know, the best practice according to the CDC is to draw it up in the home, but it said in extreme circumstances you can draw it up. And I think that given the timeframes that we have to deliver this vaccine, that pre-filling it would work. And I know they're pre-filling in Vermont. I think that, so Schelley, can you address the issue of if you have more than one nurse doing it? So generally the standard is that the nurse who's delivering the vaccine would be the one to draw it up. So if you're drawing up at the agency and you're sharing the vial with the nurse, can you just describe that process?
So what we're doing is having the nurse draw up her 5 or 6 syringes, and then the other nurse finishing with the vial, her drawing her own up and wrapping them.
Okay.
In the, I mean, ultimately, if we have 2 vials, then we send each nurse out with their own vial.
Right.
I mean, that's our standard of practice. But I mean, if we only get 1 vial and we only have 12 people, we're not. You can't switch vials halfway through like the nurse one. At least we can't. I mean, because we're sending it in 2 different directions. We're conquering 2 towns versus 1 town.
Right. And that is actually in the CDC. So one of the documents that, and I think, Lori, it's at the end of your resource list, is the CDC guidance on homebound vaccinations. And it clearly states that you should not be changing the, you know, like you can't open the vial and then halfway through your day, turn it over to somebody else.
I would never, as a nurse, I would never accept that.
Right, right.
So.
So the other thing that I did send out, and we can post it again, but Lori, I think it's in your, at the end of your resources, is there is a storage and handling guidance from the CDC. And there actually is a 1-pager with pictures that talks about how to pack a vaccine cooler. And it does describe the vaccine, you know, the cooler, and it does recommend the conditioned water bottles, with bubble wrap and that sort of thing. So that has been sent out, but we can post that again so folks have that. So with that, we still have a little more time. So I want to be sure that everybody's questions are answered. So if somebody would like to ask a question, feel free to raise your hand, and we can unmute, or you can unmute and ask a question.
I'm still a little confused, Schelley. So are you saying there were 2 nurses that gave the 11 doses that you had for the Moderna shot? Or did you give all 11 doses?
Yesterday, I mean, so tomorrow we have a clinic with 2 nurses, myself and the other nurse. All the other clinics I've done, I'm all by myself.
Okay, how long did it take you, if you're going from patient to patient, how long did it take you?
It took me, remember, I'm doing it town by town. So some of these people are on the same road. Some of these people are, you know, a couple miles from each other. So I started at 9:30 yesterday. I hit the road and I was back to the office by 12:30.
Okay, so it didn't take you that long. So if you split it up, say one nurse did 6 and you did 5, and did you do them ahead of time?
No, yesterday, no. I was the only one yesterday. Tomorrow we are going to be splitting it up and pre-filling.
Okay, so who actually keeps the vial? Because I'm so old school, you look at the vial, you look at the patient, and obviously only one of you can take that vial with you if you're doing it 2. Am I correct on that?
Right. So we, I mark them. I would mark them with a syringe, with a label,
Okay.
with the like you know, old school, you know, with a label and the number on it. So,
Okay.
and then I take a I would, you know, I can take a picture of it, and then I would probably give it to the nurse that feels, you know, wants it the most. I mean, I'm comfortable enough.
Okay.
This is not my first rodeo.
Sure. Okay. Thank
So
you.
there are a couple, my understanding, just, and I haven't heard this directly from the state, but sort of from through people sharing, is that more likely than not, we home care agencies and the RPHNs would be getting either Pfizer or J&J, so that the vials would be 5 or 6 dose vials, as opposed
then each nurse would have it.
the 10 dose vials. So if that's possible, I think that would be a better situation than having the larger dose. But so I know that Neil Twitchell is on and Danielle Morse is on. I don't know if either of you can comment on that or not. No? Okay.
No, sorry, this is Danielle. I was seeing if Neil was going to chime in. Was it about the preparation of the vaccine and how to manage it?
The question was, do you expect that for home care agencies, we'll be able to get the vaccines that have fewer doses in the vial versus the Moderna?
Yes, I believe that is the option that the state is hoping to do just for that reason, because fewer doses, less chance of waste. Sorry, I misunderstood the question.
Thank you.
Yeah, thank you. And Gina, this is Neil. I'll just reinforce what Danielle said. That is the goal, certainly, is to make this as easy as possible for you all. And that's one way of us doing it. And then also on some of the other issues that have been raised about the issues really that revolve around best practice versus what's practical. And I am not a clinician, I will let everybody know. I think all the information that's been provided is in line really with what's practical for home care agencies to be doing this. And then lastly, just on behalf of the department and the Division of Public Health Services, we really want to thank you all for participating in this effort. It's obviously a very labor intensive population for all of us to try to get vaccinated, but obviously is a very high priority. So we really look forward to everybody working this to the greatest extent that they can with their regional public health network so that we can get these patients vaccinated in a timely way. Thank you all.
Great. Are there any other questions?
I just wanted to ask a question about all the paperwork, because I know with the testing, we got the consents and everything else we needed. So are we going to be getting the agreement from the state, or as Lori said, we have to look online for the agreement, the consent forms and things like that? The other thing I wanted to ask is, I know you asked about the epinephrine, but are they going to be giving us kits of epinephrine, you know, the Benadryl, and do we have to purchase the data log? I'm not familiar with that. I've never used one. If we do have to purchase it, can you recommend a CDC approved one for us?
So great questions, Lucy. So I did notify Ann Lucy in the Division of Public Health Services about how many doses of epinephrine we need. And she did tell me that her colleagues were going to be sourcing about 100 to 150 doses, but I don't know the time frame for that, or I mean, I have a list of everybody who asked for it, but I don't know the time frame. Neil, do you know the time frame?
Sorry, Gina, I was taking a call that had come in.
Okay, I know you guys are multitasking. Do you know the time frame for Ann Lucy was sourcing epinephrine for us? Do you happen to know the time frame for when we might get that?
I do not know.
Okay, I will follow up directly with Ann. And then Lucy, I think that at the end of the document, Lori has posted the links to all the documents that you need at the end of this presentation.
Okay.
And so everything is there.
Okay.
And then what was your last question?
The data logs. I didn't know.
Oh, the data logger. Yes. So I did in my Alliance COVID update, and I can send it out again. There is a particular data logger that the state has used, and in reaching out to Lori and to Concord VNA, there's a particular data logger that for a refrigerator that it seems like everybody's using. There is a company in Kentucky called microdaq.com that sells data loggers, but they are out of stock. At least last week, they were out of stock of that particular kind. They also have some on Amazon. In the storage and handling guidelines that the CDC publishes, it does tell you what the specifications are for the data logger. So that is something that you would need to purchase yourself, and you should have one for each cooler that you're using.
Thank you.
what we were able to acquire from the public health networks with the vaccine are the syringes and needles and the vaccine cards.
Great.
Everything else was on us.
Okay, thank you.
Other questions? Well, seeing none, I really want to thank Lori and Schelley. First of all, kudos to you for launching this with your regional public health network. What a great collaborative effort. And thank you so much for sharing what you've learned. I also want to give a shout out to the regional public health folks who are on our call today. They've joined us for this. We know that you have enormous responsibilities in your communities, and we want to thank you for all you're doing and let you know that home care agencies will partner with you as best we can.
I just want to add that we have Title 20 and 3B clients down in Wolfboro that Schelley had gone out and administered vaccines to, and they refer to her as the vaccine angel. So I just also want to thank you for that.
Okay, that's great to know. Thank you, Ashley. The vaccine angel. All right. Well, thank you, everyone. And we will send out a PDF of this presentation to everybody who participated. And it's also posted on our website at homecarenh.org under under COVID-19 resources. Thanks so much and have a great day.
Thank you. You too. Bye-bye.
Thank you.
Yo, I'm just like my country, I'm young, scrappy, and hungry, and I'm not throwing away my shot. I might get a scholarship to King's College. I probably should brag, I amazed and astonished. The problem is I got a lot of brains but no polish. I gotta holler just to be heard with every word I drop knowledge. I'm a diamond in the rough, a shining piece of coal, trying to reach my goal. My power of speech, unimpeachable. Only 19, but my mind is older. These New York City streets get colder. I shoulder every word and every disadvantage. I've learned to manage. I don't have a gun to brandish. I walk these streets famished. The plan is to fan this, walk into a flame. We're getting lost. Let me spell out the name. I am the A-I-E-X-A-N-D. We are meant to be a colony that runs independently. They want Britain to keep on us endlessly. Essentially, they tax us relentlessly. When King George turns around, runs a spending spree. He ain't never gonna set his descendants free. So there will be a revolution in this century. Actually, he says in parentheses. Don't be shocked when your history book mentions me. I will lay down my life if it sets us free. Eventually, you'll see my ascendancy. And I am not thrown away, not shot. I am not thrown away, not shot. And yo, I'm just like my country. I'm young, scrappy, and hungry, and I'm not thrown away, not shot. I am not thrown away, not shot. I am not thrown away, not shot. And yo, I'm just like my country. I'm young, scrappy, and hungry, and I'm not thrown away, not shot.